He is a palliative care specialist on the team at Penn Medicine, and he's going to talk to you about palliative care and what that looks like for PSP, CBD, and MSA. And it's actually really unique to have a palliative care specialist embedded in a neurology team. So we're so glad to have him with us today. And thank you for being here and for sharing with us.
I'm a neurologist, and I did training specifically in palliative care and hospice medicine, and that's most of what I do in my career. And when I came to Penn, they had a spot waiting for me in the Cope Clinic, and it was really something I had not heard of, and I still haven't heard of really at a lot of other institutions. And so for 8 years, I've been working there, and it's been a real privilege to work with all of these folks. About 10 years ago, there was this meme that came out on the internet called "What People Think I Do," and it was real popular. It was the same format. It was 6 pictures of basically assessing what people's perspective was about X, which would go in the header there. And so, for example, doctors, right? And so what, can't hear?
Just a little bit louder.
Gotcha. So like what my friends think I do, looks like that, right? What my mom thinks I do is lift weights and work out and am healthy. What society thinks I do is use a Lamborghini for a golf cart. The government thinks I do, that's self-explanatory. What I think I do is a grumpy house MD. And then what I really do, really sort of looks, that's how my apartment looked throughout most of residency, really. It was just like that. And so I made one at the end of my fellowship for a palliative care doctor, which kind of looks like this. And so when I was training, I was told by a dear nurse practitioner colleague that, Matt, this isn't any fun to talk about at parties. And so when I'm at a party and someone asks me what I do, I say I'm a neurologist. And depending on how much more I want to talk, I'll say, but I mostly do palliative care and hospice. And usually the response is, oh. And so I'm like, it's really not, it's not that depressing. I really kind of like it. When I was well into my fellowship, I used to get a weekly call from my mom saying, hey, how are you? Are you sad? Did anyone die? Are you sad? And Mom, I'm really okay, honestly. What society thinks I do is, here's the angel of death sitting at the side of the bed saying, don't mind me, just keep going about your work. I'm gonna just pretend I'm not here. What other doctors think I do, and so I've actually been asked by some colleagues over the years, will you come make this patient DNR or DNI? I'm like, well, other than actually tattooing them with that, I don't know how I would make someone that. But again, it can be confusing for other physicians what I do. And what I think I do sort of looks like that. That's how it feels to me. And then what I really do is sort of up to you to learn. And so just by way of history, palliative care is a pretty young specialty. The term was coined in the 1970s in Montreal, ironically, because of wanting to avoid the connotations that were depressing of the word hospice. So at one point it was a euphemism for that. It's not that anymore. In 1988, there was an Academy of Hospice Physicians formed, and then in 1996, 8 years later, there was the American Board of Hospice and Palliative Medicine was incorporated. And then that became the American Academy of Hospice and Palliative Medicine that has its own conferences every year and that sort of thing. And then there were a bunch of sort of projects that sort of wanted to define what palliative care was and help people learn about what quality palliative care looks like over the next several years. And then finally in 2006, the American Board of Medical Specialties recognized the subspecialty of hospice and palliative medicine. And so the first board exam in palliative care and hospice medicine was in 2008, and these are the 10 subspecialties that people came to this through. And you can see most of it, of course, makes sense. It's internal medicine and family medicine heavy. But even then, that early, there were neurologists doing this and people from a lot of other disciplines. And this has become even more diverse at this point. People taking this board are now from many, many different disciplines. So everyone knows what care is. What's palliative care? And since I'm a big nerd, I like etymologies and Latin and Greek and things like that. And so the word palliative is a little complicated, and a lot of people have trouble when I tell them what I do, and I sometimes have to spell it. But it comes from Latin, and it comes from a verb which means to cloak or cover. And since the Roman Empire, there have been a variety of garments throughout history called a pallium, which is basically a tunic or a long cloak. And we think of palliating as reducing the distress of a disease. And so the Center to Advance Palliative Care, one of our major advocacy groups, sort of decided to poll the public and at the same time tried to push for education about what palliative care was and define it for people. and did a study in around 2011 with interviews of patients and caregivers, asking people, what do you know about palliative care? Have you heard of this? Do you know what it is? And the objectives were, again, explore awareness and understanding, but also to see how we should talk about it to people and what kind of things sound okay to people to tell them about it. And those results were published in 2011. And unsurprisingly, most people had no idea what palliative care was. And what's interesting is I assumed that over the last 10 years of doing this, that this would sort of slowly, the little Pac-Man would sort of open up. But people still often, unless they've had experience with palliative care in a family, people often don't know what that is and what it's about. And so a good part of my job is often an introduction and trying to educate people what I'm there to do in the moment so that they're not asking me to leave. And so to actually define it, palliative care is multidisciplinary medical care with a special focus. And one of the main things we do is focus on relief from symptoms. So pain, stress of a serious illness, nausea, vomiting, coughing, you name it. If there's a distressing symptom that you have in the hospital that a team is struggling to manage, sometimes we get called for that. It is available for anyone with a serious or a life-limiting illness. The goal of palliative care is always to improve quality of life for both the patient and their family. It's provided by an interdisciplinary team. That means doctors, nurses, nurse practitioners, chaplains, social workers, pharmacists, a variety of people comprise a large academic medical center palliative care team. And we like to think of ourselves and introduce ourselves as an extra layer of support. And so when you have palliative care, it doesn't mean you give up your other doctors. It doesn't mean that no one else comes to see you. It means that we're there in addition to everyone else who's already taking care of you in case you need us, and not everyone does. Palliative care is available at any age, at any stage of a serious illness, and it's independent of your goals of care. So we take care of people that are trying to be cured of cancer, and we take care of people who are nearing the end of their life. It's sort of jack of all trades when it comes to serious illness. It doesn't matter what your goals are, you can get palliative care. And it can be provided along with disease-directed therapies like chemotherapy for cancer and things like that. And there are a lot of physicians that sometimes don't really understand what palliative care is. And so when there have been times when a family I've heard of ask for palliative care for their loved one, and the physicians taking care of them say, well, I don't think we're there yet. And my response to that is, do they have a serious illness? You're there. It's possible, and especially if a family's asking, it's usually a real trigger for me, and I come running. But a lot of people still equate palliative care with hospice or end-of-life care, and it's just not the same. And I'll tell you more about that. And then sometimes, like I said, sometimes my colleagues, I don't want palliative care for my patients. They're trying to get a cure from cancer. I'm like, well, are they having pain and nausea from that chemotherapy you're giving them? I can work on that and actually make your therapy more successful. And so that's how we view ourselves when we're involved in patients who are going for a cure. And so the old model of palliative care, and how a lot of people unfortunately still see it, is that you come to the hospital with a serious illness and you're undergoing disease-directed therapies. And so you're getting chemotherapy for your cancer, or you're getting diuresis for your heart failure, or things like that. And you're doing all these things. And then at some point, we switch to palliative care, right? And then at some point after that undefined amount of time, there's hospice and or death and bereavement. And this is not really the way we've ever worked. It's really more like this, which is that palliative care is available at the time of diagnosis, depending on what your needs are, and is involved more or less over the course of your illness, until eventually we all get to hospice, and then there's death and bereavement. And so palliative care is really something that's provided along with disease-directed therapies, along with whatever is available, as an extra layer of support. And so how is it different from hospice? And this is a question I get asked a lot. And there are some pretty sharp lines, actually. Palliative care is a medical specialty. Hospice is an insurance benefit. That's the simplest one. Palliative care, as I said, is available at any time during a serious illness, and it's independent of your goals or your prognosis. If your prognosis is years and years and years, you can still have palliative care if you're struggling with a serious illness. Hospice, on the other hand, is pretty specific. The prognosis is likely 6 months or less for someone entering hospice, and physicians have to agree, 2 or more physicians have to agree that that is likely your prognosis, and that's a qualifier for that. And so that, Again, that is not the case for palliative care at all. And once again, palliative care is independent of your goals. It can be provided along with life-prolonging or curative therapies. And hospice is more focused towards comfort and things that are sort of more expensive or no longer working. For example, chemotherapy at end-stage cancer are not provided by hospice. That's just sort of the focus is different at that point. So who needs palliative care anyway? That's another question I get asked. So I'll give you a few examples. A 68-year-old guy with stage 4 lung cancer who's received 2 cycles of first chemotherapy regimen, currently in the ICU with sepsis. He's recently dependent on a ventilator and states he no longer wants any cancer-directed therapy and wants to go home and be comfortable. His family, including his wife, who is his power of attorney, are urging him to undergo further treatment, and his oncologist feels that further treatment could actually prolong his life. He's considering undergoing further treatment. Here's another case, a 55-year-old woman with advanced heart disease who's had 3 hospital stays in the past year. Her medical team's worried that their interventions are becoming less effective at keeping her symptoms under control and keeping her out of the hospital. Her goal is to live as long as possible independently in her home. And here's the last one, a 63-year-old man who's slowly become weaker and less communicative over the past year and is now mostly dependent on a walker and assistance to get around after having several falls. He was suspected to have a neurologic condition for some time and was recently diagnosed with likely PSP after seeing a neurologist. His wife and children are worried about what is ahead for him, and he states that the most important thing to him is spending quality time with his family. And so, of course, all 3 of these cases are really wide open for palliative care and in a few different domains. One of them is discussion of further goals of care or treatment. So whether or not our guy with lung cancer wants to have further chemotherapy for his cancer. That's a difficult decision some people face. And it's true that if he were to decide no longer to have any cancer-directed therapy, he may at that point be a candidate for hospice care, but palliative care is there to help sort of figure these things out with a family and a patient and sort of help them answer these questions for themselves. Advanced heart therapies and their burden. So is our lady with heart failure, is she a qualifier for a VAD or some other advanced therapy or a transplant even? Palliative care is sometimes involved in extra support when these determinations are being made or as people go through their hospital course. And then, of course, with the COPE clinic, with folks with PSP, MSA, and CBD. Also, in all 3 cases, symptom management can be really big. If a guy with lung cancer decides to undergo further therapy, he may have a lot of side effects from the chemotherapy, and palliative care can help manage some of those. Heart failure has a lot of symptoms, as you know, and then, of course, folks with these illnesses tend to have a lot of different and various symptoms. And we tend to work with the neurologist in the clinic to help manage some of those. And then finally, facilitating discussions with family about expectations, prognosis, things that come up when I meet them. And this is where Lauren and I have a bit of overlap. There's quite a bit of overlap that Lauren and I have often in the clinic. And so I get asked really similar questions by patients and families with these illnesses. And so this almost serves like a mini palliative care consult right here, just going through these. And these are some of the most common things that people with PSP and with CBD and MSA ask me. And early on in my time in the clinic, I kind of would show up and would talk to people, and I wasn't really sure, like, what am I here to do? What am I here for? What is palliative care in the COPE clinic supposed to look like? And I didn't have necessarily a model for that. And I sort of figured out over time, especially noting these kinds of questions, and once in a while when patients and families are not bringing them up, sometimes I'll bring them up and say, some families ask me this, is that something you've wondered about? And so 2 of the biggest ones are, why did I get this? And is there something I did that caused it? And the answer is, we don't know. And there isn't something we can tell you that you should have avoided or done differently. And if there were, we would tell you that, but there isn't. And so that's something I try to reassure people, that it isn't their fault and it isn't something that they did wrong. Why did it take so long for someone to figure out what I have? And this is, a lot of things go into this. One of them is the exquisite rarity of these conditions. There are many physicians out there who've never seen patients with these conditions. And so, for better or for worse, medicine is still an apprenticed art where one learns by experience. And so if someone has never seen someone with PSP, you can read all you want to read about it, but it's hard to spot, especially early. And so there's that, and then the other part of that is that the testing and diagnostic procedures we have for this, these are what we refer to as clinical diagnoses. And so we learn about what you have and how it's affecting you by interviewing you and seeing you in person. And there isn't a blood test that we can do. There isn't, MRIs can show findings later on in the disease, but don't tell us anything predictively. And so I kind of talk about some of that with patients of why did I go to 4 different doctors before a neurologist told me I have PSP? A big one is, are my children or other loved ones at risk for this illness? It's surprising how many people just assume that this is the case until I bring it up and I say, you know that that's not true, right? And it can provide a lot of relief talking about that. And then a big one is, of course, what's going to happen to me as my condition worsens. And this is, again, something where Lauren and I overlap quite a bit. And some people will want to know time, and some people will want to know function, and some people want to know prognosis in a variety of different ways. And my job is to try to figure out what makes sense to tell them and how to talk about it in a way that's acceptable to them and their families. And so there's a few things to sum up about things I wish that everyone knew about palliative care. And one is that it's available at any point around and during the diagnosis of a serious illness. And so you don't have to wait until you're so far advanced. You don't have to wait until you have terrible symptoms. If you have a serious illness and you are scared of it, you can have palliative care. It's not equivalent to end-of-life care, and it is not necessarily a giving up of therapies or life-sustaining measures. So just because you said, I would like some palliative care, please, does not mean that you are giving up. It doesn't give the impression to others that you're giving up, or at least it shouldn't. And it doesn't mean that you actually have to give up any therapies or other things that you're doing. Again, it's available regardless of your goals or your prognosis. And so if you have many, many years to live, palliative care can still help you if you have a serious illness. And then there's a lot of studies that have shown, again, contrary to what some folks might believe, that palliative care has been shown to benefit people in reduction not only in symptom burden, but lower levels of anxiety and depression, and a better understanding of patients' and families' wishes. And a lot of people think that if I start talking about this a lot, I'm going to get depressed. And it's actually amazing the relief you get when, first of all, you get the right answers to things that have been bothering you. And second of all, you realize, I think Lauren highlighted this, that you can talk about it and then put it away for a long time. And having talked about it and expressed your wishes and how you feel about things and what you'd like done for you, it's not something you have to talk about every day. And so once you sort of talk about it, get it out in the open, it can actually be immensely relieving to do that, rather than anxiety-provoking or sadness-causing. And so there was a quote that I encountered at a conference back in 2014 by a doctor of nursing practice at the University of Maryland, which basically is how I've always felt about this, which is that I believe in palliative care because I know that palliative care will be for my patients what they tell me they need. And that's really been my experience to now. And that's what I've got. Any questions?
Do you need to make an appointment for palliative care, or is it virtual?
So it depends on what's going on. With this group, I'm available through the COPE clinic at UPenn, and so I sometimes do telemedicine appointments with folks. I sometimes see them as part of their appointment at the COPE clinic. The outpatient form of palliative care in a lot of areas is still being developed and rather new, and so for a lot of these things that you can imagine in cancer, things are very well developed. And so palliative care inpatient at a hospital is available for everybody. Outpatient is sometimes less available in places. And so for cancer patients, it's usually through a cancer and oncology clinic. There are some heart failure clinics that have a specialty palliative care section. But when it comes to PSP, MSA, CBD, and things that are seen in the COPE clinic, it's just a matter of contacting the COPE clinic and saying, I'd like to talk to somebody about this and about quality of life and about goals and things like that. And it's usually half an hour to an hour session where we just sort of meet each other and figure out what your questions are and how we can help.
You mentioned that you and Lauren sometimes have to partner up and everything. Specifically, have you run across patients and I'll talk about PSP because that's the disease that my partner is dealing with, who have basically had it for a number of years but have never gotten to the point of psychologically dealing with it, so that they really don't even, if you ask them, how are you feeling, they'll say, great. And how are you doing? And it would take being with them for long periods of time before some of the behaviors or delusions or whatever would come out for you to discover. How do you two, this is like a joint question, how do you deal with that issue? Because I think the caregivers see it more often than the practitioners do. And it's painful for us to see this continuing to go on, and there seems to be very little that non-professionals can do to actually keep things moving forward. And so it sounds like, to me, palliative care combined with social work or psychology could possibly help some patients, but there are some that those ideas are just like from outer space. So you could address that. Thank you.
Yeah, we know. I see lots of patients that come in and I say, how are you doing? And they say, I'm fine. And their caregiver says, they're not fine. You didn't see them yesterday. You know, that sort of thing. It's common. And it's really hard to manage. And I think one of the things we try to do is make sure that the caregivers themselves are getting enough support themselves, because everyone thinks about supporting the patient, but again, palliative care is a focus on everybody. And I'm sure Lauren would say the same. I think I recommend often therapy, psychotherapy, behavioral therapy to patients and families who are going through this, particularly when that's an issue. There are some people that really do just fine and don't really need that. I think everyone would benefit from psychotherapy, but not everybody can really get it. But there are some cases where we see folks struggling, and that would really be a way to help further coping. And I think that's something that I've recommended before many times when that seems to be, when it's not so much I'm in pain, but I'm struggling is what I hear when those are the kind of things I think about. I don't know if Lauren, you wanted to comment further on that, or if I...
Thank you. So he might not have the words to know how to express how he's feeling, and that might be part of it. And it could also just be a lack of insight. You know, you might be seeing that he's struggling, but maybe he can't express it because he doesn't even realize his own impairments, or his own limitations. So it could be a combination of that too. So that's something to keep in mind.
Question over here as well.
Thank you for your presentation. A follow-up to the first question you had. After we meet you and we have the initial 30 minutes to an hour, what does palliative care look like after that? How often will we be in contact with you? Can you just elaborate on what happens after the initial meeting? Thank you.
Sure. I think in terms of this set of diseases, and the COPE clinic is a unique sort of circumstance in that there are really a whole host of resources available, and I don't find that people need to meet with me weekly or monthly or even that often. I sometimes find that one session of talking together is plenty until things either change or until someone feels that they want to talk again. I think because the COPE clinic has so many specialists in so many domains, when someone is struggling with, for example, speech or with movement, there are a lot of other specialists that can get involved and continue to help with that. But thankfully, you know, I don't see people who need to talk to me that often, frankly. I think, you know, knowing that I'm there, knowing that we can talk about things is, and then sort of that talking about things and getting questions answered and getting things out is really, I've seen it be pretty sustaining. And so thankfully, you know, I'm definitely available for contact as often as needed, but I'm not really contacted terribly often in repeat, as it were. And so I think going forward, the other thing that I think it's important to mention is that I'm really not the only person who does palliative care. The entire clinic does. I'm specialty trained in palliative care and communication and things like that, but really when the speech and occupational therapists are taking care of you, when you're talking with Lauren, all these folks are providing palliative care as well. And so it really is a combined team approach, no matter where it is.
And Dr. Mendlik, can I just add one thing over here?
Yeah.
I also just wanted to mention that you can also receive palliative care at home or wherever home is so Penn has a home palliative care program, and that looks like different specialists, so physical, occupational, speech therapist, a social worker, chaplain, nurse, kind of a whole team approach also in the home that insurance covers. But I will mention, depending on where you live, different agencies have different team members that are on a palliative care team. So it could just be a nurse practitioner and a social worker or a home health aide. It might not be the full team approach. So just kind of keeping that in mind.
I was wondering how you think about the stigma associated with getting a disease. So, for example, our mother didn't tell her friends for years, and now she has no friends left because they all thought she was just avoiding them. I mean, is this something common? How do we think about this? How do you think about this?
I see a lot of patients who no longer want to go out of the house or be in public because they look so different, and it's a really hard thing. I think psychotherapy can help with that, but it is really, really challenging. I think there's no right answer, and I think it's definitely an individual case-by-case basis. There are plenty of people that I've seen that really don't care and go out in public all the time, and there are other people that are intensely bothered by it. And so I think it's a matter of sort of identifying that and who needs help with that and how much we can help them. And there are some people that, even with all the help in the world, are just never going to feel comfortable being seen so differently or being felt that they're being seen so differently by people who've known them for so long. It can be really, really challenging in that regard.
Hi. We have an appointment with the palliative care specialist coming up in 2 weeks. And do you recommend that the caregivers go with the patient? I mean, what do we expect out of this first meeting? Because we've done all the other steps. And the patient really doesn't want any care, and we're living with, she's going to burn down the house one day. And we are really looking to this doctor almost as a last hope for suggestions on what can be done. So I want to get a couple of questions that we could ask the doctor at our first visit and facilitate some type of help.
Well, I think it's hard to say. I mean, I don't know where you're going or what the situation is, but I think expecting any one provider to have all the answers is a lot. I think palliative care providers are notoriously open to trying to find additional resources and referrals and things like that. And I think definitely your first question, I think everybody who is interested should go. I think having everyone there to talk together is important for that provider to get their perspectives. So again, if I talk to just a patient who says everything's great, I kind of suspect it's not, but that's what I have. Whereas if I get the additional perspectives of family and caregivers, that's really helpful to know what the needs are and to help start moving in that direction. But I think certainly, where are you seeing palliative care? Like in what system?
Where? At NYU.
Okay. I'm certain they're going to have a lot of resources, and that's probably what you're going to end up having is additional people besides just that palliative care doctor to help out with what's going on.
I'm looking forward to it, kind of, because it'll be, kind of the next step, because every time we do go to the doctor, we get one of these, how are you? I'm fine. I can do all of this myself. And I just want the whole picture to come up so we could give her the help that she needs.
Yeah, I think especially in the COPE clinic, for example, in our COPE clinic at Penn, people are very good, again, a whole team approach to palliative care of realizing that it's not fine and what to do about it, and to start talking about what to do about it. I think it's, to be glib, the traditional and unfortunately really older version of neurology used to be called diagnose and adios, was here's what you have, can't do anything about it, goodbye. And it's thankfully not that way anymore, because we have, we've realized that things like palliative care and taking care of the whole family are important. And so I think, if you've been going to a movement disorder specialist to just sort of look at you or your loved one and look at them and say, well, this is how things are now, well, that isn't necessarily going to be enough. But hopefully with a palliative care clinic and with palliative care involved, you'll start to get some of those additional things, like people like Lauren, to help out with what's going on.
I just wanted to make one comment. Really nice talk. Last year, CurePSP organized a consensus paper reviewing symptomatic management of PSP and CBD that was published in, I think, July of last year. And really, I think of that as palliative care, because until we have a cure or a way of halting or slowing the progression of the disease, all care, all management of these diseases is really palliative care. Now, I think the palliative care physicians who have training and special interest in this probably do a better job of the cognitive and behavioral and social aspects of managing the disease than the average neurologist does. But what we tried to do with this consensus paper on management is to get away from that diagnose and adios mindset that neurologists have had with these neurodegenerative diseases. So if a patient, to me, if I were referring a patient to a palliative care specialist and they said, oh, am I dying? Am I hopeless that I have to go to a palliative care specialist? And I would say, no, palliative care is what I've been trying to do. It's what any good neurologist should be trying to do all along, to give medications or other types of treatments for the things that we can treat. Something for your constipation, something for your anxiety, something for your bladder control, something to help you sleep. That's all palliative care. Tell me if you disagree.
No, that's absolutely right. I read a quote about ALS specifically a number of years ago, which was that all care for ALS is palliative from the time of diagnosis, because that's what we have. And it's true is that the neurologists who choose to take care of these illnesses that we do not have treatments for are generally a special breed and have been doing palliative care for many years before there was such a thing as palliative care. And when I think it's one of the reasons it took me a little while to figure out what my role was in the clinic, because rather than to come in and provide a thing that was missing, it really felt more like I'm just coming in to help out and to sort of look at where my niche is within this clinic. And I think that's something that has been evolving over time, but definitely the clinic was doing palliative care before I showed up. Absolutely.
Any other questions for Dr. Mendlik? Oh, perfect.
Hi, thank you for everything that you have provided. One of the questions that goes through my head that I haven't really heard addressed today at all is as far as antidepressants. We're talking about everything else, but is there a way to help as far as mood stabilization, and things like that?
Yeah, I think that's definitely true. I think when it's a minor component and there's maybe a little bit of sadness or chronic anxiety, a lot of people, even a primary care doctor, will feel okay treating that. When it's really the major thing that's at issue, that's when I feel more like referral to a psychiatrist is in order to actually manage the psychopharmacotherapy around the things like symptomatic treatment that someone is already getting, because that can be a little dicey. And so when depression is severe, I think, again, I refer to the specialists who can help care for that. But certainly I think, adding a little bit of antidepressant here and there once in a while can be useful, at least as a trial to see if it's helpful. But again, when that is really the major thing, then I want to make sure that we connect people with the right resources for that.
Great. Great information. Thank you so much. Thank you, everyone.